Evening, Gurti sir.
Good evening, ma'am.
Good evening.
It's a very a topic which is close to your heart.
Yes, yes. Hi, Naveen.
Morning. Good evening, ma'am. Good evening.
Good evening, Naveen. I've
Good evening,
gone
sir.
through the article, and there is a lot of language processing algorithm, and they have used artificial intelligence at digging out the records.
Yes, sir.
It's really interesting.
Gurti sir is into artificial intelligence, Naveen.
Last 3 years,
Doing a lot of work on that.
some passion on that right now. I think, Naveen, did you tell any of your friends to join? I put a lot of things everywhere, where, problem with this type of so many things.
Recently, yesterday for the EC meeting, we were discussing for that critical care. Initially, there were some 150 people. After that, it came down to very low numbers.
That's problem. But this IM stroke subsection journal club we started, this is the third one in the process.
Okay.
First one was done by Ila Bharti, and second one was with Dr. Rajeshri from Pondicherry, Jipmer. So very well taken. And I hope.
Okay. At least we will learn, sir.
Yeah, that's all. It's adult education program for us. Naveen is going to tell us the critical appraisal of the retrospective study.
I
Very
will
hard.
do my best for this.
Actually, I'm on holiday and I'm in Hyderabad. So not in Pune.
Okay.
Tomorrow I'm going back. But, I'm in Hyderabad, my uncle's place. So I borrowed his room and to set up this.
Okay. Hello.
Good evening, sir. Sir, will you be able to join the journal club for some time? 6 o'clock, sir. Okay, okay, right. Okay, sir, no problem. Right, sir. Thank you, sir. Thank you. Jai Hind, sir. Bye.
Sunil is joining.
Ma'am, he said he'll join. He's a co-chair.
That's what.
He is coming.
What time usually we start? Are we online?
Yeah, and I'm just trying to contact him. So we are online. Naveen is here, and a few others have joined.
It's actually everybody joins in the Zoom itself. Okay.
Sunil is on some other line. I think if you want to start, ma'am, we can start anytime because Sunil will join subsequently, I think.
We are the only audience.
We wait for 5 more minutes.
We just wait for 5 minutes and start?
Yes. Yeah, 6:05 we start.
Yes.
6, okay.
Praveen, ഞാനൊരു മീറ്റിംഗിൽ ഇരിക്കുന്നത് കഴിഞ്ഞ ഉടനെ വിളിക്കട്ടെ അത് കഴിഞ്ഞ ഉടനെ വിളിക്കാം Hi, Anand.
Hi.
Hello, Anand. Good evening.
Yes. Good evening. Good evening.
Dr. Pardarai, good evening. Dr. Pardarai, are you there? Dr. Pardarai, good evening. I think he's muted.
He is muted. Yeah.
Yeah. Sir, please unmute.
Good evening, sir.
Good evening. Good evening. Welcome.
Thank you, sir.
Sir, Dr. Prasad will be joining.
I asked Dr. Prasad just now. He's in Delhi. He said he'll join in between for some time.
Oh.
I think he's in Delhi now. I just spoke to him.
He was there yesterday for the meeting.
So he may be there only. That's why.
Shall we start then?
One more.
Or wait for 2, 3. wait for
Yes, few minutes.
how many minutes is your presentation, Naveen?
Ma'am, I can finish in 30 to 35 minutes.
Okay, yeah. Then it's fine.
That will be nice. I don't know, Sunil is on a long call on somebody. I don't know, not responding. I think as a as a convener of stroke subsection of Indian Academy of Neurology, I welcome you all to this month's journal club. We have an interesting article on carotid stenting versus medical therapy. After the Acst trial, I think there's there's a very big trial which Dr. Naveen is going to discuss, and the chairpersons for this journal club, Dr. P.N. Salazar, Professor and HOD Neurologist Chitra Tirunal, and as well as co-chair is Dr. Sunil Narayan, who will be joining very soon and is slightly busy somewhere else. Conveyed to me that he'll be joining in between. So I request Dr. Salazar to start the proceedings of this evening.
Good evening and welcome to all the participants. First of all, I would like to thank Dr. Gaurti and Dr. Sunil for inviting us for this IN Stroke Subsection Journal Club. And I would like to invite Dr. Naveen, who is my postdoctoral fellow, who will be doing the journal club. We all know that asymptomatic carotid stenosis is a very controversial area when it comes to management in patients when we see them in practice. Either it may be a patient who is coming with an asymptomatic carotid stenosis just during routine evaluation, or maybe in a patient who is going for a bypass and you detect that the patient has got a carotid stenosis. Now, there is evidence being built up with regard to whether the patients with asymptomatic carotid stenosis should undergo carotid revascularization. This has mostly come from the natural history data of asymptomatic carotid stenosis showing that the risk of patients having a stroke is less than 1%. So hence, there is a lot of evidence with regard to the current intensive medical therapy is much better than what was there before. And we know that these patients do very well. But in addition, there is data accumulating suggesting that in these asymptomatic carotid stenosis, there are newer ways or newer investigations available which can identify the high-risk plaques or the high-risk features are there, which can be a vessel MR carotid plaque imaging, or it may be ultrasound carotid enhanced, contrast enhanced ultrasound, or maybe an emboli detection. These are the features which are used in these asymptomatic carotid stenosis to decide in our clinical setting to decide whether these patients should undergo revascularization. So today's topic is on carotid stenting versus medical therapy among patients with asymptomatic carotid stenosis. Over to Naveen.
Naveen, you can share the screen.
Yes. I hope my screen is visible, sir.
Yeah, it is visible.
Good evening to all my teachers and all the student faculty who are here in this forum today. First of all, I would like to thank my mentor, Dr. Salazar Madam, for giving me this opportunity to present in this prestigious forum. I would also like to thank all the senior professors in this forum for giving me this opportunity. So let me begin with the journal club discussion today.
Naveen, there is some disturbance. Okay, can you present now?
Okay. So carotid stenosis accounts for about 11.
This is better.
Okay. I have removed my headphones actually. I'm speaking diagrams. So carotid stenosis accounts for about 11% of the strokes worldwide, and the current treatment standard is carotid endarterectomy. We all know for symptomatic keratosis, the standard is carotid endarterectomy based on the 3 landmark trials, that is the NASCET, ECST, and the Veterans Affairs trials, and the pooled analysis which showed the definitive benefit. But carotid resuscitation among asymptomatic patients is a primary prevention procedure, unlike the secondary prevention which we are doing in the symptomatic patients. And trials have established that carotid endarterectomy is beneficial even in asymptomatic keratosis stenosis patients based on 3 major trials. However, so far, no RCT has directly compared carotid artery stenting to medical therapy. So these are the 3 major trials which I am talking about: the Veterans Affairs Cooperative, Study, then the asymptomatic carotid atherosclerosis study, and the asymptomatic carotid surgery trial. So all these 3 trials were done among patients, and in the pooled analysis of these 3 trials, around 5,500 participants were included. The periprocedural 30-day risk of death as well as stroke after endarterectomy was around 2.8 to 4.6%. And they have compared mainly carotid endarterectomy versus best medical therapy in asymptomatic carotid patients. And we can find that in the ACAS study, the ipsilateral stroke plus perioperative death or stroke was about 5.1% in the intervention arm compared to 11% in the medical arm. And when they analyzed as any stroke plus perioperative death or stroke, it was 12.4% versus 17.8%. The last of the 3 major trials, that is the Acst One Trial, which was conducted about 20 years back from now, that showed a benefit of about 6.4% risk of any stroke or perioperative death or stroke at 5 years analysis, and 11.8% at 5 years for the medical therapy arm. So about half the reduction in the stroke risk was observed in the endarterectomy group when compared to best medical therapy. And the percentage of stenosis included for the carotid artery disease in these trials were all more than 50%, with ACAS and ACST including predominantly more than 60% of the asymptomatic carotid stenosis. And these the later 2 trials were pivotal in developing international practice guidelines, and most of which advise that CEA should be performed with a 30-day when there is a 30-day risk of death or stroke less than 3%, and the patient is expected to survive for more than 5 years at least. So these trials form the basis of the current recommendations. So this is a 2017 European Society of Vascular Surgery guidelines. To sum up as a whole, both symptomatic as well as asymptomatic carotid stenosis. The left is the asymptomatic arm, and this is the right is the symptomatic arm. And in both the patients less than 50, 60 and less than 50%, or those with occlusion or near occlusion, the management of choice is best medical therapy. Whereas in asymptomatic carotid stenosis, our topic of interest for today, in those with stenosis about 60 to 99%, if they have a favorable life expectancy of more than 5 years with a favorable anatomy and more than or equal to 1 feature suggesting a high stroke risk while on best medical therapy, then you can consider carotid endarterectomy with the best medical therapy as a class 2A B evidence, and may be considered only as a class 2B evidence. However, what are these high risk features which they are talking about? That varies from clinical as well as the imaging point of view, like presence of a silent infarct on the ipsilateral carotid territory, or progression of stenosis in serial follow-up, whether it's ultrasound wise or CT angiography wise, or if there's a high risk plaque, like if you are doing an MR plaque imaging and finding intraplaque hemorrhage, highly lipid-rich necrotic core, or an echolution plaque in the ultrasound, or an echolution plaque near the surface with a breach of the plaque wall. All those are features such as a high risk plaque. And if more than 1 high risk feature is found, then it is an indication that you may consider doing endarterectomy or stenting in these patients. However, endarterectomy is the one which is usually approved, and stenting may be usually considered only when the patient has a contraindication for it. So for practical purposes, there is no RCT which is currently comparing stenting versus a medical therapy in patients with asymptomatic carotid stenosis. But the point to be noted is all these trials were done more than 20 years back, and when we compare the medical therapy 20 years back to what it is now, we find that there's a significant improvement in the medical therapy. Because previously they had not used this high dose statins, the antiplatelet adherence was also less, and optimal risk factor control was not there in most of the trials. And when we compare outside a trial setting, the effectiveness of the stenting versus a medical therapy may vary, because in a trial setting, there is a rigorous selection of the participants, and the trials usually recruit interventionalists who are highly specialized in doing the procedure. So the complication rates will be less, which may not be the case in a real world practice. Therefore, the risk benefit ratio of intervention may be less favorable outside an RCT point of view. So coming to the question, in a world of more aggressive medical management with lower absolute event rates, that is for asymptomatic keratosis stenosis, the absolute event rate with medical management is now less than 1% and lower procedural complications. Is intervention for asymptomatic keratosis stenosis still beneficial or not? So there is one trial which is ongoing, which will help answer this question. That is the Acst trial, which has two parallel RCTs. One arm analyzes the CEA, the endarterectomy plus intensive medical therapy versus the intensive medical therapy alone. The other arm is analyzing stenting plus intensive medical therapy versus intensive medical therapy alone. This is unlike the previous trials in which they had compared endarterectomy. So this trial is different from that in that two different modalities are compared against intensive medical therapy to find whether it is beneficial or not in this asymptomatic keratosis stenosis population. So coming to our journal topic, this is done by Saloma Kehanani et al. And they are from San Francisco. This group had previously analyzed and published in JAMA in 2020 the effectiveness of carotid endarterectomy versus initial medical therapy in patients with asymptomatic keratosis stenosis. This is not an RCT, it is a large observational study database from which data was analyzed using normal statistical methods to find whether endarterectomy versus medical therapy, which one is better for these patients. So this study was published in JAMA and it was conducted from 2018 to 2020 and the population was, this is predominantly from the Veterans Affairs database. So all the veterans aged 65 years or older who received carotid imaging between 2005 and 2009 were recruited and a cohort of patients were constructed. And this cohort, I will be showing about in detail about this methodology because the same methodology this group has applied in the current study also. They published it in 2 papers. So they used this novel method called target trial method. And this was used to replicate an RCT in an observational database study. So where many of the real world scenarios, we cannot do an RCT where it will take a longer time to get the results. So they extrapolated the same methods to an observational study to reciprocate the results. And what they found was they compared mainly CEA versus initial medical therapy, and their main outcomes was fatal and non-fatal strokes. They found that among those patients who received both carotid endarterectomy versus initial medical therapy after 1 year of the index carotid imaging, the observed rate of stroke or death was 2.5% in 30 days in the endarterectomy group. However, the 5-year risk of fatal and non-fatal strokes was lower in the endarterectomy arm compared to the medical therapy arm. But when they analyzed for competing causes of death, that is, the patient might have undergone endarterectomy or a medical therapy, but might have died due to another causes, like for example, cancer. So when those risk factors were adjusted and analyzed, they found that there was no difference in outcomes between these two. There was no statistically significant risk reduction in this population. So accounting for the competing risk resulted in a risk difference of 0.9% with a confidence interval spanning from -2.9 to +0.7. That was not statistically significant. So this study found that the absolute reduction in the risk of fatal and non-fatal strokes with early CEA was less than half the risk difference in trials from 20 years back and was no longer statistically significant when the competing risk of non-stroke deaths were accounted for in the analysis. So this was another novel proposition. Based on this, they also did one more study comparing effectiveness of stenting versus medical therapy in patients with asymptomatic keratosis stenosis, which is our journal for discussion today. So this was published in Stroke, Journal of the Stroke. This was in February 2022. The study hypothesis was medical therapy, that is medical treatment arm, is a more favorable treatment strategy compared with stenting among patients with asymptomatic keratosis stenosis. The study population is patients in the Veterans Affairs cohort who received initial diagnostic carotid imaging with either ultrasound, CT or MR angiogram between 2005 to 2009. And at least 1 year to the Veterans Affairs Cooperative Hospital should be there before to ensure basic baseline data. So 1 year prior to the enrollment, they should have at least visited the hospital once to have baseline data. And after that, they should have had an imaging index carotid imaging, which is taken as a time 0. And all patients with carotid imaging tests who had a stroke or TIA in the 6 months prior to the imaging, that is, if they have an indication for imaging because of a stroke or TIA, they were excluded. And all patients who received an endarterectomy or a stenting in 6 months prior to the index carotid image were also excluded. So that they excluded all patients who have received intervention for the symptomatic stenosis. And the data were extracted from the Veterans Affairs Corporate Data Warehouse and Medicare data. they also have this suicide data repository. This repository maintains the all the veterans' details regarding the vital status, their deaths, and the cause of deaths of all the military personnel. And they use the natural language processing algorithm called Raker's algorithm, in which that algorithm will run through the entire database to find all text reports mentioning with less than 50% keratostenosis, so that they will be excluded. And then one independent human reviewer will identify all the reports mentioning more than 70% keratostenosis, or reports with the terminologies like near occlusion, critical stenosis, or severe stenosis. So one reviewer will independently search for all these text reports and filter out from the database. And they assign a time 0, that is the starting point, as the time of the first keratid image, which demonstrates stenosis. And when they compare the baseline comorbidities between those who received intervention and those who did not receive intervention, there was significant disparity between them. This is expected because the ones who are having higher risk factors with more comorbidities are more likely to end up having keratid stenosis and end up getting an intervention. So what they did was a propensity score matching was used to construct a sample of medical therapy patients similar to those undergoing intervention. That is the same risk factor profile, same age, same almost same other body mass index, blood pressure parameters were used to construct a matched cohort, but they did not receive intervention. And using this propensity score matching, they used the nearest neighbor match to select the patients who are very similar to the intervention patients. Second, they defined intervention as patient should receive intervention. That is, intervention here denotes carotid artery stenting within 1 year of carotid after index carotid imaging. So the target trial was early intervention, that is stenting within 1 year, versus initial medical management, that is initial medical therapy group. So this is the cohort construction. So 65 years and older with a carotid image report between 2005 to 2009 who did not have any symptoms, ischemic symptoms in the prior 6 months were first screened. And this was this text was processed using a natural language algorithm. Any carotid term they found around 200,000, and of this the image report was only for 170,000, with around 206,000 notes were there. Then those less than 70% carotid stenosis were excluded, and a human reviewer independently searched all these abstracts to look for those with carotid stenosis more than 70%. So that came to 13,371. This was randomized into early intervention and delayed intervention. Early intervention meaning they are receiving stenting within 1 year, and delayed intervention is those assigned to medical therapy and followed up. Because this delayed intervention arm around 9,500, and there was significant baseline demographic mismatch between these two cohorts, a propensity matching score matching was used to identify medical therapy cases which were similar to the intervention cases. So once they did that, almost similar numbers were found for the intervention arm, that is the stenting, versus the delayed intervention, that is the medical therapy arm. So 3,795 and 3,888 patients were recruited. Then the detailed medical records were reviewed. Again, this is by a manual human review of the medical records, and out of which those who are missed from this but still having less than 70% stenosis were excluded 872. Patients who had symptoms mentioned symptoms in the past 6 months were excluded, and those who underwent intervention outside hospital with no corroborative data available for review, those were excluded. And in some cases, the investigator or the treating doctor has specifically mentioned in the case file that this patient is a post-surgical candidate. So for reasons like cancer or some other significant comorbidity, those were also excluded. So excluding all these patients, there were about 2,700 patients available for early intervention. This early intervention was divided into 2 groups, one in the endarterectomy arm and one in the stenting arm, and the delayed intervention was the medical therapy group. So 2,500 patients were in medical therapy alone initially. So this early intervention arm is the one that which they reported as a separate paper comparing with the medical therapy group. And the current journal, they included this comparison between early intervention with stenting versus the medical therapy group. The reason they did that in 2 separate papers was the sample size was not proportionate. There was an unequally less number of patients in the stenting arm to limit any meaningful triple comparisons between the groups. So they published CEA versus medical therapy as a separate paper and stenting versus medical therapy as a separate paper. The primary outcome was fatal and non-fatal stroke, and stroke events being followed by assessed using the textual high specificity algorithm. So this algorithm also scans the medical records for words like stroke, TAA, recurrent stroke, postoperative, fatal, using the words keywords. And all patients were followed from the date of the first carotid image, that is the time 0, and up to 5 years. So the statistical analysis they used here, the Kaplan-Meier curves were computed to estimate the stroke risk, and they used this target trial method, wherein they are emulating the trial, that is the Acst One, which was the last conducted trial in asymptomatic stenosis, where they compared an intervention with a medical therapy group. So they emulated the inclusion-exclusion criteria of that trial, wherein again patients should be having stenosis of at least more than 60% with no symptoms corresponding to the ipsilateral hemisphere, and the patient should be a candidate for either endarterectomy or stenting, but the investigator as well as the physician should be unsure of which arm to assign the patient, and they should be having they can have iris features that prompted them to go for intervention. The trial also excluded patients with competing sources of a stroke. That is, if the patient had a concurrent CABG and a procedure, or a aortic valve replacement and a procedure, that is either stenting or endarterectomy, they were excluded. This is mainly to exclude non-atherosclerotic, that is cardiac sources of emboli, which can also cause a stroke. So they excluded those patients. So this target trial method attempts to emulate the Acst One trial by incorporating the inclusion and exclusion criteria from that trial, but in this observational study database. They randomly assigned, so in this study, they randomly assigned each subject at baseline to one of the treatment groups, either a stenting group or a initial medical therapy group that may be possibly contrary to the treatment that the patient actually received. So as such, if they could have analyzed both the groups by seeing who all received stenting and who all received medical therapy, and then they could have analyzed, but that will be an observational study. So they want to replicate the randomized trial data here. So without knowing which patient underwent which therapy, they randomly, using algorithms, they randomly assigned each patient at baseline to either of the two treatment groups. So it is possible that a patient who was actually received stenting could be assigned to the medical therapy group, and a patient who had actually received medical therapy group could have been assigned to the stenting group. So what they did was, the subjects were followed after assigning to either of the two arms. They were then followed up using observational data until either of the 4 endpoints here. So the endpoints could be an occurrence of a fatal or non-fatal stroke. That is their primary outcome. Or it could be because the study period has ended. That is 5 years the endpoint have reached, and then they have stopped analyzing them. Or the treatment status became inconsistent with their assigned treatment status. So somebody they assigned to patient A, they assigned it to medical therapy group. But on follow-up, they found that patient A had received stenting at a later point in time. So the patient A is no longer consistent with the medical therapy arm, and now he has switched his treatment from medical therapy to stenting. So there is an inconsistency in the treatment assigned for this patient. So that will be an endpoint for that patient. And or it can be that the patients have changed their insurance care providers such that the procedures, whatever they are receiving, would not be captured or would not be accounted for in the data set. So only when they are accounted for by the provider, insurance provider, they will have the data and rate the procedures captured. Otherwise, it will be lost to follow up. So either of these 4 points was used as an outcome point. So this is again what I was telling. So a patient could be randomized to patient A might have actually received either medical therapy or stenting therapy, but he could be randomized to medical therapy arm. But if he undergoes stenting within 1 year for some indication, it may not be symptomatic. For some other indication, he has underwent stenting within 1 year, then the patient will be censored. Similarly, a patient is randomized to a stenting arm, but on 1 year follow-up, we find that this patient has never underwent stenting. So he is also to be censored, because this patient could have actually been originally received only the medical therapy arm, and we had randomly assigned him to stenting arm, and we are following him for 1 year. So these patients will be censored. That is the endpoint for that patient. So while we are cutting the patients, we are censoring the patients at various time points, there is an informative loss occurring because due to treatment switching, we are not following the original per protocol analysis. Rather, we have wanted, it is not because of treatment switching, the patient's treatment also gets varied. So we cannot do the per protocol analysis here. So to account for informative censoring due to this switching, there is a statistical method called inverse probability of censoring weights was used. So I will explain about this. This is a method in which they use a Cox model that measures using two variables. One is the baseline variables, which are time invariant, and time varying covariates. So time varying variables and time invariant variables were used. This to account for any baseline differences between the groups, as well as the possibility that the patient may develop a condition that may render them ineligible to the assigned arm. So cancer is a time varying variable. The patient, when he is assigned a treatment, for example, stenting, on follow-up by 1 year, if he develops a cancer, he will become ineligible to get a stenting because of a cancer. His survival may be less than 5 years. So he may be ineligible to the assigned treatment arm. So here there is a condition which may confound the treatment assignment also. So let us take this example. Suppose there are two treatments. So this inverse probability of censoring weights was originally taken from oncology studies, where they are assigned a true, where they give two different treatments to compare the efficacy and to account for the crossing over between the treatment arms. So suppose drug A and drug B were given for patients, and patients in drug treatment A were all switching to treatment B because of significant adverse effects in treatment A. Then there will be many crossovers from treatment A to B. So how do they account for this crossing over without losing the original weightage of each patient assigned to the respected arms? So what they do is they assign more weight to the patients who remain unswitched from treatment A to B. That is the remaining patients here. And they assign less weight to the switched patients. All these red patients, they will be assigning a less weight, and those who are not switched but remaining the same treatment group from the beginning will be given more weightage. So the likelihood of remaining uncensored, that is the remaining patients, the likelihood of remaining uncensored, this is estimated by a logistic regression using the two variables which I mentioned, that is the patient baseline and some time varying covariates. The coefficient between these two probabilities will give the assigned weight for each of the variables. So based on this, they give a weighting for each of the variables. So what they did in this study was, these are the baseline variables which were included in the study model, which were time invariant, and these are time varying models. Like for example, a patient race, ethnicity, married status, veteran priority score, all these will remain the same. If it's a hypertension, hyperlipidemia, diabetes, all these will remain the same. So these scores were all given. These are the baseline variables which have a weightage. But they also have to take into account time varying variables. Like these patients, because of these risk factors, can get hospitalized. He can develop an acute MI. He may undergo an intervention, a new CHF diagnosis, COPD diagnosis. Because of these risk factors itself, the diabetes status itself may fluctuate, and he became poorly uncontrolled diabetes. All these high risk features like GI bleed, cancer, coagulopathy, thrombocytopenia, or new hemiplegia, all these things are time varying variables which need not stay in the same state also. Like a patient, if he develops a new congestive heart failure, that may also improve over time. So all these were taken as time varying variables. Each of these variables are assigned a weighted score to account for possible switching between the treatment arms. And they defined severe heart failure as EF less than 35 or a hospitalization in the past 6 months, and severe COPD as the post expiratory volume in 1 second of less than 30% predicted, or a hospitalization in the past 6 months. Then they used Cox proportional hazards for estimating the outcome. The outcome is fatal and non-fatal stroke as a function of the indicator variable. We cannot use this Cox proportional hazards model in some of these studies. Like for example, if you compare a stenting patient and a medical therapy patient, the stenting patient is expected to have a higher perioperative adverse events. So if you look at immediately in the first 30 days, the risk may be higher for stenting and it may be lower for stenting. But over time, we find that the risk in stenting is mainly peri-procedural, and over the time the risk is expected to decrease, and the benefit due to the reopening of the vessel is expected to come up here. Whereas in medical therapy, the risk will be negligible initially, but over time it may increase also. So we can find that the two curves cross. So when the two curves cross, you cannot use Cox proportional hazards model. So this model was originally developed for survival analysis. Suppose treatment A is 2 times riskier than treatment B at a point A, then at point B at a later point of also, the risk should be maintained. So it cannot be that a person can die twice the other treatment in the initial part, and later they can survive twice better than the other treatment at the later point. So that will violate this proportional hazards model. So they cannot use this proportional hazards assumption for estimating as a function of the indicator variable. So what they did was they reported only 5-year fatal and non-fatal stroke risks alone. So risk they can estimate, and they had to account for competing risks, that is the deaths due to other causes, and they re-estimated the 5-year risk of fatal and non-fatal stroke after accounting for competing risks also. Somebody may develop a new cancer and develop a cancer-related coagulopathy causing a stroke. It may not be because of stenting, it may not be because of medical therapy. So this is the competing risk which will affect the final outcome also. So they did analysis in 2 ways. One is by the target trial protocol, wherein they emulated the Acst One Trial, and they wanted to analyze the risk. And also they accounted for competing risk and due to other causes to estimate the risk of fatal and non-fatal stroke in both the groups. So as I told earlier, this study mainly compared the early intervention, that is the stenting, versus the delayed intervention, that is the initial medical therapy group. And this is the baseline characteristics of the cohort based on the actual treatment received. So the stenting arm is only 550 patients, whereas the medical therapy arm 2,500 patients. Predominantly, this is an elderly population. 74 years is the mean age of the patients. And we can find that the propensity score matching has worked really well because the standardized differences are less than 20 for most of the matched variables. So it is comparable. We can tell that these 2 cohorts are comparable, but there are few instances which few of the variables which we have to pay attention to. This population is predominantly an elderly one. Almost 93% to 94 of them are like white population, and it is a male dominant population. And we can find that the presence of ischemic heart disease was higher in the stenting group, and the presence of the medical therapy group had no congestive heart failure, 49 versus 65, 36 patients with a standardized difference more than 20, 0.20. 20% is like 0.20 here. So we can find that this ischemic heart disease prevalence was higher in the stenting group. More of these patients had congestive heart failure. More of them had a COPD, which is moderate to severe, 17 versus 8 compared to the medical therapy group. And the other vital statistics were comparable between both the groups, including the presence of renal failure, blood pressure parameters, obesity, procedures. All of them were like comparable. But ICU visits and hospital admissions were again more frequent in the stenting group. Along with the usage of antiplatelets were comparable in both the groups. 88% versus 85% was not very higher, the differences. But anti-anginals were higher in the stenting group when compared to the medical therapy group. So overall, the stenting group patients had more percentage of ischemic heart disease, COPD, anti-anginal use, frequent ICU visits and hospitalizations, thus giving us a hint that these were a sicker portion of the cohort actually. And this is their 5-year stroke risk, which they had calculated. This is based on the actual treatment received. So this is an observed data in which the perioperative complications were 2.2%. In asymptomatic stenosis, less than 3% is what is recommended. Here, this cohort had 2.2% as the perioperative complications at 30 days. And the 5-year risk of stroke risk was 10.3 in the stenting group and 6.9 in the initial medical therapy group. But this is not a weight adjusted analysis. So this is based on the actual observation. And the observed 5-year survival was about 62% survived in the stenting group and 67% survived in the medical therapy group at 5 years. So around 1/3 of them did not survive by the end of 5 years. But when they incorporated this target trial method and they reanalyzed the same observational data using randomization and then that inverse probability of computing of censoring weights, then they found that 5-year stroke risk in stenting group was 6.9%, whereas in the medical therapy group was 7.1%. The risk difference is not at all significant. It is only 0.1% better in the stenting compared to the medical therapy group. And the significance is also not there because it ranges from confidence interval ranges from 2.6 minus to 2.7 plus. And when they took into account the competing risk like other causes of death, then the 5-year stroke risk even drops further to 4.7% in the stenting group and to 6.2% in the medical therapy group. But even with this drop also, the absolute difference between these two groups was only minus 1.5%. That is, the stenting group fared better than the medical therapy group by only 1.5% reduction. This was also not statistically significant. That is because the confidence interval ranges from -3 to 0.3. So there can be a room for marginal benefit to marginal harm also. So which again denotes no statistical significance and hence no meaningful response there. So this is the Kaplan-Meier curves which they have plotted using a target trial method. This is the survival probability of at 5 years, stroke-free survival probability when they randomized to stenting versus medical therapy group. We can find that the two curves are almost comparable. The red one is the stenting group and the blue one is the medical therapy group. And this is after adjusting for baseline characteristics and incorporating the inverse probability of censoring weights in the analysis. So the risk difference, although stenting is slightly showing a lower, the curve of the stenting group after the initial point, by the time it goes to 1000 days and by the time it comes to 5 years, it has dropped. The survival probability has come to somewhere around 92%, 93%. The medical therapy also falls around the same level by 5 years. So by 5 years, there is no significant difference between both the groups. When the same curve is plotted as the cumulative incidence of stroke. This is the survival stroke-free survival curve. This is the cumulative incidence of stroke curve. So after accounting for competing risk, the in the stenting group it was 4.7%, less than the 5% you can see here. By 5 years, that is 1,500 days, it is 4.7% in the stenting group and 6.2% in the medical therapy group. Again, this was not statistically significant. So coming to the discussion, both the main analysis and analysis including the competing risk suggest that the stenting did not offer an advantage in terms of stroke reduction compared with initial medical therapy alone. And this population was a predominantly elderly male population. The perioperative complication was less than 2.2%. Trials have recommended that it should be less than 3%, but real world data up to 4% also have been reported in asymptomatic cases. And one important point is to be noticed that 1 in 3 patients did not survive 5 years, whether they were in the medical therapy arm or in the stenting arm. So it is possible that if you have selected the patient for stenting and if they have a shorter life expectancy, if 1/3 did not survive 5 years, then they may not have enough stroke-free years to actually offset the increased short-term risk following a stenting itself. So that may be one reason why it may not show the benefit of stenting compared to medical therapy. And there was a significant room for improvement in the risk factor control in both arms. They found that in the observational data, 1/5 of the patients were not on antiplatelet therapy at all. 1/3 were not adherent to statins, and there was room for improvement in BP control. So despite substantial room for improvement in risk factor control, the 5-year risk of stroke in the medical therapy arm was only 6.9%. The original ACST trial reported 11% risk of stroke at 5 years in the medical therapy arm. Here they found only 6.9%. So even with still room for risk factor optimization, the medical therapy arm was not very significantly affected here. Then a key issue to consider in this study is that the intervention could have been done any time after the image. So they assigned time 0 as the first carotid image done for some reason, but it was not symptomatic. And they could have done the intervention. They categorized intervention as less than 1 year. So less than 1 year means the patient could have underwent stenting within 1 month, or it could be at 6 months, or even at 1 year also. So this could lead to an entity called immortal time bias. So what do they mean by immortal time bias is, suppose we are discharging an example I would like to give here. Suppose we are discharging two asthma patients from our hospital, and after discharge, we plan to start them on corticosteroids. So we assume that giving steroids, those patients are less likely to have been bedridden by the end of 3 months. So we will write corticosteroids at the description, at the discharge summary, and we give the patient. But after discharge, say 2 patients, say for example, one patient is getting the prescription at 1 month, and the other patient is not at all getting the prescription. So the 1 month, the patient who took the prescription at 1 month will continue to show some benefit, will start accruing the benefit maybe, but by 3 months when we see, we will write that the patient has improved because of corticosteroids. But in the initial 1 month, he has not taken any treatment. Still, he had no event due to the asthma. He has not bedridden. So without even giving the drug of interest, the patient has actually survived the initial part without anything. So this is called immortal time bias. So what the most possible error which we make is, we will think that at discharge and at 3 months, in the 3 months interval, the patient had not had any events. But actually the patient would have taken the drug 1 month after discharge. So the actual event-free interval would have only been 2 months. So we should avoid this immortal time bias. So there are various analyses to avoid this bias. One is the use of a landmark analysis. So landmark analysis is we discharge the patients and then we will say, for example, at 2 months, I will put a landmark, and anybody who has not had an event, I will start analyzing the patients after 2 months. So this will avoid the immortal time bias because you are starting to analyze the patients from 2 months onwards, irrespective of whether they have taken the drug or not. So, but the fallacy with the landmark analysis, it results in exclusion of all early events. If you take the current trial into example here, for example, they suppose a patient underwent stenting at 1 year, and you say landmark analysis will be starting from 1 year onwards. That is 1 year after the index therapeutic image, which means the patient would have underwent stenting somewhere around 10 months, and you will exclude the early perioperative risk of stenting and then start analyzing the patient from 1 year onwards. So this would artificially make the stenting arm look safer because the early perioperative stroke events will be missed. And this will not give you any information to make clinical decisions because the early complications are excluded. So they did not use landmark analysis in this study. Another method they could have used for analysis is the Cox proportional hazards regression model. This I had already told. When you're comparing two interventions like stenting and medical therapy, when the curves are expected to cross, because the treatment may have an early risk period, but later have a big benefit. So the early risk will not be reflected in the medical therapy arm, but the benefit the intervention will cause the curve to dip. So the two curves will cross. If the curves are crossing, the use of Cox proportional hazards model will not be an ideal one to use it because it will result in fallacious itself. Second thing, this Cox proportional hazards regression model will result only in estimation of relative hazard ratio and not the absolute risk reduction. We all know in the gold standard why we tell us RCTs is because we will be able to find absolute risk reduction, and from that we will be able to get the number needed to treat. That is one by absolute risk reduction. But in observational studies, we will not be able to get this absolute risk reduction. We will only be getting a relative hazard ratio. But using the target trial method, they were able to estimate the absolute risk reduction in the risk of outcome. So this will help in mimicking an RCT and also account for immortal time bias. Thereby, the time varying confounding is also taken care of here. But in this study, the absolute risk reduction was minus 1.5, but it was not statistically significant. So there is no meaning to the result which we have got there. Coming to the limitations of the study, the randomization and blinding are the most crucial elements in an RCT, which are difficult to emulate in an observational study. And although they did propensity score matching, which can approximate randomization, like almost it can bring the both a comparison, baseline characteristics between the two groups comparable, but it cannot account for unmeasured confounders. So if we are doing a study in which we are expecting a lot of unmeasured confounders to be present, then doing a propensity score matching will give you a fallacious result. And also, perioperative strokes were accounted for in the outcome of fatal and non-fatal strokes over 5 years of follow-up, but they did not report the perioperative complication of death as a result of stenting. They mentioned that they were not able to get the data for death. So following a stenting procedure, patients can die also, but that complication is not accounted for in this. And this is predominantly an EMR review actually, so medical record review. So there's a possibility that they have missed stroke events that were not coded or that were not documented. And these findings are applicable only to elderly white veterans, which are highly selected population. We are an entirely different population, and this result should be held with caution. The success of this model, that is the inverse probability of censoring weights, this rests on the assumption that we have measured almost all the adequate variables which could possibly affect the results. So if there is an unmeasured variable which could account or which could confound this, that we cannot account for. So that cannot be accounted in this analysis. And it is possible that the subject's treatment became discordant to which they were originally randomized for reasons that they were unable to capture. Somebody might have been assigned a treatment to stenting arm, but they ended up getting a medical therapy for unknown reasons that they were not able to capture. They have included that also in the analysis. And the stenting size is the population is only 551. So that they mentioned it as a modest sample size. So what does this study implicate for us? The target trial method, that early evaluations using this target trial methods initially started in oncology practice, and now it is coming in a big way in stroke also. These can more closely approximate the results of RCTs in selected instances. It is this will in no way is a substitute to an RCT, which are still the gold standard, but RCTs are costly and slow, and in some instances are not feasible also. There may be instances where there is a therapeutic equipoise and we cannot do an RCT in them. So in such instances, the target trial method, if emulated in the future and is found to be accurate consistently, it opens a new world for researchers with large observational databases. So this is what they are proposing is they have already made 2 papers out of these methods. One is comparing endarterectomy versus medical therapy, the other is stenting versus medical therapy now. So there's an ongoing Acst Two trial also. Once the results comes, it will be interesting to see how these results correlate with that study results. And if it's correlating well, then we will expect many more such analysis to come back in the future. So to conclude, in the sample of older male adults, there was no difference between the medical therapy and the stenting in treatment of asymptomatic keratosis. Future studies are needed to confirm these findings. Thank you.
Thank you, Naveen. That was a very good presentation, I would say, going in detail into the statistical part. In fact, it was a very complicated statistical analysis and modeling which was done and very fantastically presented. And I have a few comments in this paper. As you have already mentioned, we know that doing large, you need very large number to do trials on asymptomatic carotid stenosis because we are looking at a very low risk of stroke and you need large population. So that is why if you look at, we do not have enough data. And in that setting, I think even though with all these limitations, the important point is that these kind of large, we have to use large observational data only to come to form some form of hypothesis, which may lead on to bigger RCTs. So that is one of the basic message in this paper. Second, I would say is that I think the target trial method, it has got definitely its advantages because in observational data, that is the only way we can look into the randomization. But there are a lot of lacunae in the study which needs to be considered when we are making some conclusions or some implications of this trial in the clinical practice. So what we are looking for in these kind of data is to see how much it will have implications in a clinical decision making for us for the future. So that way, I would say there is a lot of limitations because one is with regard to the patients, a significant number of the patients had died and we do not know their long-term follow-up. What we are looking for in patients with asymptomatic carotid stenosis is not the earlier period of risk. What we are looking at is long-term, how it is going to have our information so that you can decide whether, that is why we look at what is the survival of these patients with regard to planning your treatment. So that way, that information. And second important point, which they mentioned, I still find it difficult to make out regarding the assigning a patient to carotid endarterectomy versus carotid stenting versus medical treatment was randomly assigned, whether it was endarterectomy. Can you explain that again? I was still not clear how they can use that data to make any conclusion.
So what they're telling is that first they have this 500 outpatients in stenting. This is the cohort. So early intervention is 3,795 and delayed intervention is 3,888. So when the medical record review, they found that this many patients underwent.
No, that we understood. How does that help in the later part? They censored it, no? That's what they told.
Yes, ma'am. So
but that will have a lot of implications in the results, no?
They have censored. What they tell is once they have censored, and that censoring is accounted for by this inverse probability of censoring weights. They use this analysis.
I think that is all just statistical work, but I do not know how much it can be of practice. No, that is a major point, no? We are talking about two kinds of treatment, how it is going to make a difference. And we are randomly assigning them. And when they have been randomly wrongly assigned, those are all censored. So what is the final? So it's not a thing which we can finally make any conclusion from that. But I think one of the important point is that when you do not have much evidence on this, as I already mentioned, this kind of information will have a lot of implication. I would like to open it up to all the rest of the participants, Dr. Gaurti, Dr. Anand.
Actually, it's a retrospective study, and they tried bringing randomization in a different way, the target method. Actually, it is not that. There is no real robustness in this finding. But one thing is good. This is the one which they showed that medical treatment is equally effective. And from ACST, 11% has come down to 69%. The post-stroke, this thing. That's a good sign. You have to devise a prospective randomized controlled trial to really test medical therapy, which is much better than the days when NICAS and other things were done. Dr. Anand, you want to contribute, Dr. Partha?
No, I think as Dr. Salja mentioned, I think on the first time when you read it, I think it's a little unsettling, when they do this trial method, because the target, trial method, because we are used to this, very ideal world of randomized control trial. But I think the way they end and the way he summarized, I think it's going to be very difficult. And I think that's what we are seeing even with Rescue. I think Rescue started 5-6 years ago, and it's taking another 3-4 years. And during that whole trial, and we went through this with the ACST and both asymptomatic carotid study trials, that it took 10 years to complete a trial. And what happens in those 10 years, things significantly change in terms of not only the stents that are available, but medical treatment. So I think it's a thought-provoking method, and I think something that we need to think, I thought even more so in an Indian setting where the variance of treatment, what happens on ground level is very different. So I think at the end of it, I think I have to commend the authors, I think for number one, collecting the data, which they do in the veteran world. And this probably mimics the real life situation, unlike, what happens in RCT. So I think at least those are the two positives that I would take on it. Because it's going to be very difficult to do RCTs, and more so in resource deprived setting like us. So as I said, my first comment was, okay, the drawbacks are very obvious, but I think in the end, I think I enjoyed reading the paper. I didn't understand the statistical part of how, they made these patients from RCT into the target trial method. So that part, technically that's my drawback. But I think in the end, I think it's a good paper. It's a good paper because it reflects real life ground level scenario of practice that we all practice, and good collection of data.
Dr. Partha?
Yes, thank you. Yeah, thank you, Dr. Naveen. I enjoyed your presentation. It's very good. I'm learning the critical appraisal theme very much. Now, some comments following on what Professor Sailaja and Professor Anand just now said about some new statistical principles, IPCW, the target trial protocol. These are alternatives to the traditional randomized control trials. So that's something I learned. Now, I was a bit curious about this 1 in 3 people dying in less than 5 years as part of this, the presentation and the study that the authors have done. Next thing I have to comment upon that this was basically a comparison of best medical therapy. And you pointed out the variations in the practice of best medical therapy. It was quite suboptimum, as you did point out, in many of the best medical therapies. So it wasn't the best anyway. And the basic comparator was carotid endarterectomy. That was the thing. Isn't that right? Or have I got it mixed up a bit? Or should there have been 3 arms? Because stenting, endarterectomy, and best medical therapy are 3 different interventions. And we are here clubbing the stenting and endarterectomy together, or did we leave out the stenting completely? I wasn't very clear.
We left out the endarterectomy group and compared only the medical and the stenting group.
All right, so the stenting was compared to, so what stent was used, what was the skill of the surgeon also needs to be incorporated in this. And that's a very, very determinant factor in any of these trials. But yeah, they've done a good job. They've gone into it very critically. And the more I'm thinking about your reflections on your presentation, the more questions that are arising as to whether best medical treatment is basically better than all these surgical interventions in any setting, including in sort of hopefully good centers that they have been practicing out of. And again, for these interventions, I think we have to emphasize on the type of the stent, the operator, their experience before recommending any treatment. for the patients, because with the best medical therapy is very easy to achieve. It's standardized, doses and all the rest of it. But you had even a statin difference, and the cholesterol levels and all the rest of it hasn't been mentioned. You did touch upon the plaque and the plaque characteristics as well, which was very interesting. But I've read the paper, but it wasn't really detailed. Was it your reflection on how they should have done it? Or was it in the supplementaries? I didn't quite catch the ultrasound of the plaques, the embolization. It's not in the actual paper. Where did you get the data from?
Yes, sir, it was not in the actual paper. They are not, I was trying to mention, because they are not looked into the plaque characteristics. They did not try to find the high-risk patients like that. They did not subcategorize like that. When we look at asymptomatic keratosis, we will search for these features, but they have not done it like that. In fact, the indication for imaging and how did they end up choosing the intervention was not mentioned.
Right.
But Naveen, it's a retrospective data analysis.
Yes.
So whatever happened in the past, they're trying to look at it, see whether it is appropriate to equally to a randomized control trial with a statistical jiggery-pokery, to tell you the truth. But yes, it's an elderly population. One thing good is, despite so many drawbacks with medical treatment, that the poor adherence, it has shown a good result. That means since the time we had a lot major trials, medical treatment has changed completely. Now it is given us a hope that, okay, we don't have to do stenting for poor people. We can give them best medical treatment and prolong and remove the stroke problem. So that's the thing which I got from this trial.
I fully agree with Dr. Gurti regarding that, because that is an important information. Even though they had showed a very small percentage of patients who are not being taking treatment, about some 5 or 6% who are not on antiplatelets or statins, which you showed.
That's right.
And we are really not sure what is the target risk factor control, how intensive was their control. Still, the medical treatment did well in these patients. So that's what. So this is a hypothesis generating thing with regard to whether we should really go ahead doing large RCTs in the asymptomatic keratosis group.
Is it
because what are you going to gain by doing such large studies, spending so much of money? Is it really worth it? Is the question.
Very reassuring is our medical treatment works. So we don't have to clamor for other interventions. You treat effectively and follow them up till we have the results from major trials like Acst 2 and others.
And again, this is extracranial artery stenosis. We're not even discussing intracranial artery stenosis, which is more relevant to our context. So do they have any data? They haven't. They just focused on carotid artery. Yeah. So there's no information whatsoever about any level of intracranial stenosis that they might have had, or not at all. We do not know that, do we?
I think they have not looked at
They
the
not
mentioned paper, yeah. And the 11% that we quoted from the first 3 original trials that we had, which was the best medical therapy, we had a good chart, table 1, you called it, to the 6.9 reduction is just because of, differential reporting or better treatment now compared to 20 years ago when the medical therapy was even worse compliant and worse standard. So what do you think is the difference in the 11% before and 6.9% now? What are your thoughts?
It may be because of the improvement in the medical therapy that we find that 1/5 was not on antiplatelet therapy and 1/3 were not adherent to statins. It's possible that the improvement is reflected in these patients, and there is also significant attrition also. 1/3 did not survive. So there may be differential reporting as well. Both may contribute to this 6.9.
Why do you think was the survival rate so low? 1 in 3 after undergoing such a intervention with a short-term mortality risk, not pull it through for more than 5 years. What was the reason there? Curiously,
they are not reported on the death, sir. That is one thing they had.
Cancers, you said.
They have not mentioned on the perioperative death rate as well as why they died. That was not mentioned actually. They had not mentioned about that part.
If I can comment on this, not on the basis of absolutely the data is not there. This is your classical Veterans Affairs American population. They, a lot of them smoke. A lot of depression. Not very regular with treatment. So this is not even your average Caucasian American. This is your Veterans Affairs. It's a socialist. I don't know. United States, the healthcare system is not socialist, but the VA affairs system is pretty socialist.
Yeah.
So I think it's not surprising, but again, not indicative of the regular American population. So this is your classical VA population, they take life as it goes.
There was a European study the paper refers to. The European-based trial was halted due to inadequate recruitment. Have you seen that, Dr. Naveen, in the very first paragraph of your paper? And they had one European-based trial was halted due to inadequate recruitment. It says your reference number 6 in the paper.
Phase 2 trial. They were telling about the Phase 2.
Yeah. Phase 2, Phase 2 trial. Have you had a chance to look at that as to what happened? We're just following on Professor Anand's thing that this was a VA trial, so it might have other social and psychiatric comorbidities, just a normal STEM population from Europe. Why could they not? They were doing the same thing, you see, in this in the Phase 2.
Endactytemy, actually.
Sorry, what was it? What happened there?
That study, they actually looked at both endactytemy, stenting, and medical therapy, not primarily stenting versus medical therapy.
Yeah, that was the trial I was proposing, that a 3-arm trial is more meaningful. If it needs doing, as we think it may not be really answering the international question, neither the Indian question, but just for science and for understanding pathology, the Phase 2 got stopped because it was inadequate. Is that right?
So I'm not sure about that. Why?
That's what they say in the paper. They had a inadequate.
They mentioned that the interim results only were there. They were not compared to the trial, did not proceed further.
Do we have any feel about the dose of statins they were using here? Because atorvastatin, has always been underused. 80 milligrams for adults is the standard dose, But, I've seen in India 10 milligrams, 20 milligrams, up to 40, anything above that. I have not seen many prescriptions,
They don't tolerate, sir. Problem is that.
I tolerate 80, sir, for the last, 10 years.
You are exception, but
I'm genetically Indian, sir.
Yes. No, Dr. Partha, what Gaurav is telling, and definitely the tolerance with regard to higher dose is not very good. But there are patients who tolerate higher doses, but most of the time when we put on higher doses, their tolerance comes down, and what happens is they become non-compliant to the medication. They stop the medication. Right. So we do not want to take the risk of stopping the medication rather than at least continuing the 40 milligram atorvastatin. So that's the only reason. I don't think there is any data to suggest, but we have seen patients complaining. So that is the only thing. So most of the time we tend to use only 40 milligram. But our cardiologists are very regularly using 80 milligram.
Absolutely. I've seen a vast difference in ezetimibe and 80 milligrams of atorvastatin following cardiac consultations, whereas neurology consultations, although, but that will affect the anti-inflammatory effect as well as the cholesterol intralipid plaque architecture longer term. And that has got a huge, rather soon enough difference in the plaque architecture, which is the turning point of reducing morbidity. So maybe higher dose of, do we have an Indian Stroke Association guideline of what the ideal atorvastatin or statin dose should be?
We have got the Indian Stroke Association guideline, in which what I remember is it is 40 milligram, but that's not recent. 40 milligram, but that is not recent. Recent guidelines have not been updated.
And is that weight adjusted, or is it just a standard for any weight?
Oh, it's not weight adjusted, standard.
Again, so again, that is another big issue about things, and then whether we combine. Well, PSK9 is not yet there, but ezetimibe and what is the ideal cholesterol level target for Indians for prevention of strokes, secondary prevention of strokes? It's 3.5 or lower.
We usually use the Sampras data of secondary prevention with keeping the LDL, especially in atherosclerotic disease patients, we keep the LDL target of less than 70.
Right. So it's a subfraction target. Okay. Total cholesterol level targets, because 3.5 is the Scottish trial data. A total cholesterol less than 3.5. That's what I target. But if the Indian guidelines focus on LDL, so be it. And that's achievable with the 40 milligram atorvastatin, we think.
Yes. We keep patients with less than 70 with 40 milligram.
Okay.
We usually keep them for 3 months on 40 milligram, and then depending upon the LDL and the cholesterol status, bring down the statins at 3 months.
I'd like to congratulate Dr. Naveen once again for a wonderful presentation and the long, hard work that has gone into this very succinct presentation. Thank you very much, Dr. Naveen. Very grateful.
Thank you, Naveen. It was very good. And thanks to all the participants, Dr. Partha, Dr. Gauti, Dr. Anand, and all the participants who have joined on a Monday evening. And thanks, Gauti, for the opportunity.
Yeah. Oh, ma'am. Thank you, Dr. Naveen. Thank you very much for a wonderful presentation. I thank Dr. Salazar for sharing the session and all the participants for their elegant discussions which we had. Hope to see you on next Journal Club next month, June 1st, Monday.
Thank
and
you.
Cheers.
Very
And
nice.
good night for all.
Thank you.